Good morning, everyone. We're going to go ahead and get started. Thank you so much for being here. My name is Reid. I am a Black woman wearing a red dress and glasses. I have curly hair, and I'm delighted to be the moderator of this session. I serve as the policy director of the George Washington University Funders Forum on Accountable Health. And just to ground the conversation and what brings our colleagues from Texas and California together today, wanted to provide just a little bit of context into our shared work. So the Funders Forum on Accountable Health, our work is rooted in the Accountable Health Communities Demonstration Project, the Centers for Medicare and Medicaid Innovation Demonstration Project that ran from 2017 to 2022. But beyond that, this table of philanthropic funders now focuses more broadly on multi-sector community-based partnerships that work to bring together healthcare, public health, social services, other local partners, and importantly, community residents, so that we together can address unmet health and social needs. So the table of funders includes the Blue Cross and Blue Shield of North Carolina Foundation, the Blue Shield of California Foundation, California Endowment, Commonwealth Fund, Episcopal Health Foundation, Kresge Foundation, Robert Wood Johnson Foundation, St. David's Foundation, and the W.K. Kellogg Foundation. So since the impetus of the Funders Forum work back in 2017, we've studied model components that are central to this work. So the features include having a shared vision, really centering equity in everything that we're doing. Governance, having shared decision-making and thinking about what that looks like across all partners. Community voice, and we'll really delve into that and speak at length about that today. Portfolio of interventions, having a trusted organization that's serving as the backbone within the community, data analytics, and sustainability. So importantly, these partnerships are one vehicle to center community voice in governance and resource allocation within communities, many of which have been impacted by structural racism and other patterns of disinvestment. Our panelists today will highlight 2 accountable communities for health that are part of broader initiatives within their respective states. Ener Chiu and Carolyn Johnson, or CJ, will describe work in Oakland, California, that's part of the California Accountable Communities for Health Initiative. Ener serves as the Vice President of Community Building at the East Bay Asian Local Development Corporation, the current backbone organization of that work in Oakland. And as Ener and Carolyn, CJ will describe, the backbone function is transitioning to the Black Cultural Zone, of which Carolyn, for CJ, is the CEO. Our final presenter, Amy Hooten, will share efforts in Longview, Texas, that are part of the Texas Accountable Communities for Health Initiative. Amy chairs the GLOW Steering Committee, and she'll speak more about that capacity. And with that, I will turn the floor over to Ener and to CJ.
Thank you so much. Hi, everyone. Good morning. Welcome. Good morning. My name, once again, is Ener Chiu, and I use he, him pronouns. And I'm an Asian American man wearing a purple shirt, dark pants, and in case anyone's curious, Adidas kicks. I'm asked to describe myself also as well. My short and nearsighted wife, very kind and lovely person, described me as very tall and very handsome, but only from a distance. So keep your distance. I'm excited to be here this morning to talk about the Healthy Havens Core Collaborative, or HHC, out of East Oakland. And some of you may know East Oakland as the place where Steph Curry's Golden State Warriors basketball team won 4 titles before the owner moved them to San Francisco. Or where the Oakland Raiders football team won 2 Super Bowls before the owners moved them to Los Angeles, and then back to Oakland, and now on to Las Vegas. Or the Oakland A's baseball team, who won 4 World Series in Oakland before the owners moved them to Sacramento next year and to Las Vegas after that. So you can see that Oakland is the kind of town that's experienced a lot of success and a lot of hard work as well. And as a city, one of the main everyday tragedies that we're dealing with is the fact that more than 1 in every 100 residents in our city experiences homelessness. 1% may sound like a manageable statistic, but I can assure you it is an overwhelming reality, and it costs our fellow human beings and our community enormously in terms of shared essential dignity and as a fiscal drain to public and private health and wealth. And that's why dealing with its upstream causes and downstream symptoms is the main focus of our Kachi learning agenda. So the Havens Court neighborhood is next door to where all of those teams that I mentioned used to play. And you can tell I'm really not bitter about it at all. But it's located in this orange trapezoid neighborhood in East Oakland. And historically, prior to World War II, it was really a working class, quite prosperous community, with some residential blocks being very segregated for whites only, while other areas, primarily closer to where kind of the food processing and automobile manufacturing areas were located, they tended to be more multiracial in character. You've probably heard of the practice of, actually, before I do that, I just want to, out of curiosity, how many folks here are from California? Okay, so 3-4 people. And how many folks here are actually consider yourself to work outside of kind of the healthcare industry? Same. Oh, similar. So 3 or 4, very few. Okay, so we're a small tight knit bunch here. You've probably heard, many of you are in healthcare, so maybe you've heard of the practice of redlining, whereby the federal government allowed and even encouraged quasi-public and private lenders to systematically deny home loans, insurance, and other financial services to neighborhoods that had too many non-white residents. You can see this practice visualized in a map from 1939 that was produced by the Federal Homeowners Loan Corporation, or HOLC, which showed in red the areas where they actively discouraged lending and investment. So when we say that a community has been historically disinvested in, this is literally what we mean. 75% of the communities that had been redlined by HOLC are today low income, which is a self-fulfilling prophecy if there ever was one. I was told that y'all love data. So here's what the neighborhood looks like according to the most recent census. In 2020, there were 15% more residents there than what were counted in 2010. And we think that 2020 census was likely an undercount. There has not been a 15% increase in the housing stock, which means that households are now overcrowding more people into the same number of homes. And we find that pretty consistent with conditions in many poor places across the country. From the 1960s to the 1990s, the area had been majority Black, but starting in the 1980s, the neighborhood began seeing increasing number of refugees and immigrants moving in from Southeast Asia, Latin America, and the Middle East. And from a public health perspective, this is one of the most polluted communities in California in terms of air quality, resulting in one of the highest rates of ER visits for asthma. So again, I work for an organization called the East Bay Asian Local Development Corporation. It was founded 50 years ago in Oakland, Chinatown, a neighborhood that's about 5 miles west of Havens Court. We were invited in to assist the Oakland Housing Authority to redevelop a highly dysfunctional public housing site called Coliseum Gardens, again, named for its proximity to the Oakland Coliseum where all those teams used to play. The neighborhood had been known as a hotbed of intense poverty, drug dealing, and gang wars, but also had the highest proportion of Asian Pacific Islanders in the housing authority's portfolio. And so together with our development partners, we tore down 169 dilapidated and unsafe homes. And in its place, we built 567 new mixed income homes surrounding a large central public park. And in consultation with residents and neighbors, we renamed the community Lion Creek Crossings, named after the natural creek that runs through the area. Like a lot of community development projects, like a lot of community development projects, we lead with affordable housing development. But we know that safe and affordable housing is just one social determinant that influences how healthy a community is. And so we developed other place-based programming here that focuses on family well-being including free and low-cost childcare, free one-on-one individualized financial coaching, and tax preparation services. And because community work is even more broad than any one organization can hold, we work with partners to convene the initial Healthy Havens Court Collaborative, HHC, which at the beginning focused on healthy housing, the well-being of children, and reducing asthma incidences in the neighborhood. And we've been so lucky to partner with many organizations that are based in or work in the Havens Court neighborhood in East Oakland. And so now that we've been in the backbone role for the past 5 years, the collaborative is strong enough for us to transition this really central and important role to a comprehensive community development partner and convener that is more directly based in this neighborhood. And so with that, I'm so honored to pass to introduce my colleague, CJ from the Black Cultural Zone.
Thank you, Ener. Good morning, everyone. It's morning in California. So it's a pleasure to be here and to really enjoy working closely with Ener for nearly 2 years now. I met Ener first as their director of commercial real estate at Ebalsi, and since 2019, and we've continued that partnership between the Black Cultural Zone, which was formed in 2019, and Ebalsi. I'm also a native of East Oakland, born and raised right in this area all of my life, and just am excited to see the focus on East Oakland. So I really want to say I appreciate Ebalsi because this is important, transitioning and partnering with emerging organizations like the Black Cultural Zone, and doing so with responsibility and care and consideration and technical assistance is ensuring the long-term success of the Healthy Havens Court Collaborative. So I want to talk a little bit about, the wrong way. I don't know which way, but okay, right. I want to talk a little bit about the Black Cultural Zone. So the Black Cultural Zone is 3 things. It is a geographic area. So you see here in the yellow is the entire East Oakland Black Cultural Zone that we've designated. And it is about half of the city of Oakland. And we picked this neighborhood because it has remaining the highest concentration of African Americans in a location in California next to Los Angeles. Oakland, due to redlining, was a primarily Black city in about the late 1970s, about 51% African American. With gentrification and displacement, it is now projected that by 2040, the Black population will be less than 10%. This large corridor, which runs down the middle of Oakland, at one point had 1,000 Black-owned businesses. They either owned or controlled their real estate on that corridor. After a major project that came through called the Bus Rapid Transit, and the community knew that infrastructure projects for our community means displacement. And they said, we need a Black Cultural Zone as a concept. But subsequently, at this point in time, there are only 4 Black-owned businesses that own or control their real estate in Oakland. And so the point of the Black Cultural Zone is that we are doing everything that we can to retain the Black community, to resource those who are there, and to return the Black community as well to this neighborhood. This neighborhood, as opposed to other parts of Oakland, has lower density, still has homes with backyards. And so we don't have to displace any of our Black and brown folks who have come to the community, who we are happy to have there, because Oakland is very diverse. And I grew up loving that and don't want to lose that. But we can build up. We can convert single families to 4 families. We can add ADUs in the backyard. So we are looking to preserve the character and culture of Oakland, which really relies on comprehensive diversity. I grew up with every ethnicity and want to make sure that the Black community remains there. Our goal is to develop 10 Black Cultural Zone hubs in this 40 by 40 or East Oakland Black Cultural Zone area to make sure that our presence remains with a strong economic base and also with housing as well. 70% of the folks who are unhoused in Oakland, living in tents currently on these corridors and under railroad tracks and alleys, are African American people, many of which who had a home at one point. And Ener mentioned in the 80s that there was a shift in terms of folks coming into the community, but that shift was also due to Black folks losing their home. People who watch Snowfall, those kind of shows. There was a true epidemic, crack epidemic, which is now a public health crisis, but it was a criminal issue in the 80s, really cost a lot of people their homes, their ability to live, and the resources that folks had spent so much time building. Well, we're here to partner with organizations like Evolve and others who are doing place-based things to hold and build equity and health and access for all communities in Oakland. So I want to talk a little bit about our project that we're doing, which is here. We are building a market hall, a 30,000 square foot market hall that will house East Oakland businesses, cultural businesses, because we truly believe that given all of the national and international organization and sports teams leaving, we don't want to rely in Oakland on these big boxers. They come, they deplete, and then they leave. People were crying about, some people not from Oakland were crying about In-N-Out is leaving, Denny's is leaving. And I was like, who's been to Denny's in the last 20 years? And so we go up the street, down the corner. And so we're building a market hall that will be a food hall, an event hall, a performance hall that really highlights our talent. There will be maker spaces on the second floor, rooftop bar and garden in the back. You'll see that there is, or we call it the Red Building. We had a big fight, push with our architects who, when you tend to design affordable housing, we always say, why does that look like a prison? We don't want our spaces to look like a prison. We want it to look brilliant and beautiful, and that everyone deserves the best. So we have 119 units of affordable housing and a place that we call Liberation Park. Liberation Park was a vacant lot on a corner in East Oakland next to a formerly vibrant real estate, retail, commercial space. And eventually the whole mall has become basically a police station and has become a place for healthcare and resources, but no retail. And this little corner lot had been overgrown for 10 years. And we took it and we converted it to a thriving economic hub. And then eventually, of course, when we did it, the city says, well, let's put it up for sale. So we fought really hard to make sure that we kept it. And so we've been approved recently in March to actually develop this property. And so this property will be a real central hub over here in this corner, exactly where it is for Healthy Havens Court. There is no real retail in East Oakland. There's no place to go that's nice like that in Oakland. So this will be a hub for that. And we believe cultural equity, health equity really requires people having things that remind them of themselves, brings back community, brings back local. It is essential to health, to give people a place to live, to give people a place to earn a living, to give people a place to work with folks who look like them and remind them of themselves and support them in who they are. So this is a really important part of the partnership between our organization and Egalsi with HHC. So I want to talk a little bit about Healthy Havens Court Collaborative. When I was working at Egalsi and they were building out the Healthy Havens Court Collaborative in East Oakland, again, I perked my ears up because this is home for me. And we have a set of core partners. They're key to making this off. The one thing I love about the work we're doing in Oakland is that it's very collaborative. We move as a pack. We support each other because we understand that we call it One Oakland. We will live, thrive, or fail and die together. And so we have to support each other. We uniquely know our stories. And every city and every place has to understand that it takes locals to also understand who you are and welcome those who bring the ideas. But if you don't ground it in community and community perspective, then you're sort of doing things for them without them. And Oakland is definitely can't do anything for us without us, and that's critical. So our core partners include the United Way, the Oakland Unified School District, which is huge. So many of our babies are in the school district, and we have to interact with the school district as well. Currently, the head of the school district is an East Oakland native. Roots Community Health and La Clinica de la Raza, two healthcare institutions that uniquely serve our organizations. Bananas supports children, Alameda County, and a lot of resident leaders. Those are our core partners that we move with and meet with. And our priorities for HHC is wellness, family wellness, which isn't always just about healthcare. It's about mental health and wellness, spiritual health and wellness, and how you ground yourself. So when you go to Liberation Park, you'll hear drumming, you'll hear music. I always tell folks that sometimes we want to play our music really loud. And if you don't like it, you might want to maybe say barbecue baby. People call the police on people at the lake for barbecuing. And Oakland is so just unreal. And we have to welcome our newcomers and understand who we are, because when you make people feel unsafe to be in their community, that you will call the police on them for playing music loud, it's almost like a death threat. And so we want to make sure that everyone feels welcome and respects each other, but also doesn't cause further harm. Jobs are critical, not just any job. Jobs that lead somewhere. AI is taking over. And so we really want to focus on jobs and careers. And then, of course, housing. not just housing, but healthy housing. What does it mean to have a home that's full of neighbors, full of friends and family, that is safe, that is clean, and making sure that people are living in good condition? I showed you the building. It should be beautiful. It should make people feel like they deserve to be there. So in HHC 2.0, we had a first version and a second version. There was a huge community planning process with residents, really through art and culture, kind of telling us what they want and what they see. We're very clear that people don't always communicate in the ways that other folks would accept. Draw it for us, share with us, tell us what you want, speak to us, and tell us what you're thinking about. And so it's just important to talk a little bit about how we go about community planning to really integrate. There is not a person in Havens Court that's not aware of Public Havens Court Collective, because you have to speak to the folks. When the guy on the corner can tell you about your program, then you know you're being successful. So I want to talk a little bit about how it works. When I talk about community stewards, one of the things, being a native of East Oakland, when I really got into the nonprofit world, there are thousands of nonprofits, and I never knew about them. I don't know what they were doing. I know that there is I say this gently, a negative correlation between the proliferation of nonprofit organizations and Black wealth. And so that negative correlation means something's not right. And so it's really important to us that we resource people that are from the community, and we call them community stewards. They're ambassadors that walk up and down our corridors to talk to our business owners, our unhoused community, people that we went to school with, grew up with, messengers who we resource, people who live on a neighborhood for 5 years to go and give resources, information to their neighbors who trust them, and bring back information, and making sure that we're talking to each other. And community health workers as well, because at some point, everyone is going to go through the healthcare system, whether they're in an unhoused space and Roots is going there taking care of them. But connecting those two, the commercial corridor, the neighborhood, and the healthcare all together, and making sure that it's based in place. I was talking to Ener earlier that there's parts of Oakland I never went to as a kid. I lived kind of within a 10 block box. And each of those neighborhoods is different. Havens Court is different than the Elmhurst community, for example. So it's got to make sense there. We were blessed to have funding. We have funding from philanthropic organizations. California here is relatively blessed with philanthropy as compared to some other communities. The CACHI grant has really been able to help support the transition from EBALTSI, backboning, not leaving, but backboning to Black Cultural Zone backboning, the organization, and bridging us to more sustainable funding. Because this work, as you know, as a CEO, it always, at night, you'd be amazed. I think about the 800 or 80 lives that are waiting for us to make sure that we have the funds to support them. And yet sometimes, county, the city funding does not fund at break even. And then, so that's one of the challenges. And so Cal AIM, which Ener will come back up and talk more about, being able to use state Medi-Cal in a way that can help provide sort of that stability and support for the program. We have to look at all tranches of capitalization, philanthropic, government, fee for service, all ways to do so. And so with that, I'm going to bring Ener up, whose team has taken some time to do that work.
Thank you. So I'm going to wrap our Oakland part up by just noting that CJ and I both work for comprehensive community development corporations, or CDCs, whose work aims to improve the health of our communities. But the outcomes and outputs that we're used to counting are actually different from those found in healthcare by the things that you all count. We're used to counting the number of homes built, the number of commercial leases inked, the number of people that we provide a specific service, but we're not trained to take case management notes or track client interactions at 15-minute intervals. And so, and the agencies and institutions that we have historically worked with are also different. I've actually never been to a conference where I literally don't know anyone else other than CJ. This is like my first time. And I'm like, oh, usually I go when I see a lot of people that I know. So our learning curve has really been steep. And it's important to note that our CACHI grant is resourcing us to begin to learn this medical system, which is what we're doing now in Vital Care. So speaking for EBALTSI, we're at least a year out from implementing any service that would qualify for CalAIM reimbursement. This pyramid actually shows what our understanding is of how Medicaid dollars flow into our local communities in California. And so we as community-based organizations really have two options of how to engage the system. The option on the right, is to contract directly with MCP, which in our area is the Alameda Alliance for Health, or Kaiser Permanente. And this would mean that we would be managing our residents and clients' Medi-Cal eligibility, enrollment, and authorization for services. We would have to build out the infrastructure and systems to manage compliance, privacy, security, and case management. Having seen my friends in the community health clinic world navigate this and try to build out their organization's internal infrastructure, I really can't see a housing-based organization like the Balti taking that path. And so the option on the left is to subcontract with the county health system, which in our area is the Alameda County Healthcare Services Agency, or HCSA. And in this case, we would act as a subcontractor provider, providing enhanced care management or tenancy sustaining services. And here the county would manage the Medi-Cal eligibility, enrollment, et cetera. And they already have the infrastructure and programs in place to manage the program. We just need to learn those systems and ensure that our organizations are complying with their procedures. So to wrap, I'm just going to say this really quickly for time. There's two programs that our HHC has kind of actively implemented in our neighborhood. First, collectively, we've built and managed almost 750 below market rate homes in and adjacent to the Havensward neighborhood. And that's so common. We've also trained and supported, just in the past 3 years, 5 neighborhood leaders who have learned about the risks of mold, lead, and pests to their health. And they've also learned about tenants' rights and political engagement. Think about a landlord that is training their tenants in tenant rights. And they've used those skills to connect with 960 of their neighbors in 2020 and 2021, the first 2 years of COVID. I don't know do you guys remember COVID? Like, were you guys going out and talking to 960 people in COVID? These people did. And those leaders have gotten their neighbors to advocate for upstream interventions, pushing the city to use their lead exposure settlement resources to start a proactive rental inspection program. So the second program that we've been really successful at developing is called the Lion Creek Cup House, the Havensward Cup House, which is a multi-organizational one-stop hub for expecting parents or parents with children between 0 and 5 that offers healthcare navigation, play groups, support groups, childcare resources, and one-on-one financial coaching in a neighborhood that has one of the highest density of young children in the city. So at the end of the day, we are trying to translate some of the successes that we've had in building and managing below market rate housing, and developing and providing resident-driven programming across organizations. And we're trying to use that as a foundation to meet a need in our community that is crying out for solutions. We need to connect people who have been living outside for a long time to safe, affordable housing. And once they're in the housing, we need intensive case management to help them rebuild the habits that they once had. They had at some point in their lives when they did live inside with housed neighbors. We want to do this by utilizing and resourcing staff who these vulnerable clients already know and trust. People who are working not inside hospitals and institutions, but who are instead, as CJ was saying, already walking the streets that they're on or staffed in the buildings where they already live. And we want to ensure that a disinvested neighborhood like East Oakland has equitable access to the healthcare and wealth building resources that have historically been denied there. So that's the goal that HHC would like to accomplish as a COTCHE grantee. And with that, I'd love to turn it over to Amy Hooten from Texas to help us learn a little bit about some of the things that they've already achieved that we're hoping to learn from you.
Hello, everyone. This is going to be an example of kind of a reverse approach to the same concept. So, my name's Amy Hooten. I'm the EMS chief for the city of Longview. We run the 911 system for the city and handle the 911 EMS calls for the city. And so, when our partners came together during COVID, what we were doing was a shot clinic, because in our city, when things happen that need to be taken care of, the fire department, the city, the county, we come together, and whether it be a disaster or whatever it is, and we ran a a collaborative hub for vaccines. We did over 70,000 vaccines for over a long period of time. And the reason this is important, two things, is our collaborative came together at the end of, at the end of COVID. That's when Episcopal Health Foundation approached one of our partners, Community Health Corps, which is our mental health authority, with a grant opportunity. And because of COVID and some other collaborative things we had done in the past, we came together and looked at this opportunity to work to look at the high utilizers of the 911 system and re-engage them in a different way, a more proactive way, by identifying those needs. And what we found is it wasn't necessarily medical needs that these individuals were having. They were these non-medical drivers of health, such as housing, transportation, and access to care. So in 2021, Greater Longview Optimal Wellness was created with the funds from Episcopal Health Foundation, and then later St. David's also funded us. And our partners include the Gray County, the City of Longview, Community Health Corps, which is our mental health authority, 2 FQHCs, and both of our local hospitals. We have 2 hospitals in our community. We went to each one of those partners and brought them along. Oh, and I didn't mention Greater Longview United Way as well. So we're relatively new compared to our counterparts here. But we initially started the grant looking at the high utilizers of the 911 system. We have many individuals that will call 911 sometimes up to 4 times a day just to go for food or shelter into the ED. And so these are, using up our 911 services, which is your most expensive medical costs, your ED visits and your ambulance visits. And so when we started digging into this issue and seeing what was really going on, we realized that these individuals didn't have access to the proper things that they needed. And so that led us, so overall we've probably been working with patients for our clients for about 2 years. We had initially identified those high utilizers and went to them and asked if we could. They have to sign a consent form for HIPAA and to be in the program. It's a free program. It just allows us to communicate on their medical needs and their non-medical drivers of health needs with these partners. And so the individuals sign a consent form that allow us to communicate and work through their needs. And we sit down with them with a CMS screening form and look at what their needs are. And we work together and develop a plan with the individual. And so nothing we do is done without the individual's consent. And then we just work through their highest need of the day. These are 911 folks that what you typically wouldn't think of as a 911 call, but for them, it is a 911 call. And so when we initially encounter someone, we try to mitigate their initial needs quickly, and we use some systems that we have in place. We have an app that we use where it's basically a group medical text where we can initially talk to all the partners and consult in real time on an individual's needs, just to stabilize them for that initial time to keep them from going to the ED. Once we get them stabilized, of course, it's a long process to help with whatever they need and to just work through that individuals. It's on a case-by-case basis on what the individual needs. So initially, these are some of our statistics. 119 folks. We're a new entity, and like I say, we've only been working with patients about a year and a half. To 2 years. I always call them patients because I'm a medical person, but these are more clients that we work with. And so I won't read all these statistics. I know you've had a chance to, but we came in from a needs basis, and then we broke it down to our demographics. And sometimes they're like, how do you work on non-medical drivers of health? You're the medical people. What do you do? And I think just listening to what my colleagues had to say, you can see how it crosses over. And when we came together, we started meeting and we formed our steering committee. We've been meeting once a month. This entire committee has been meeting once a month since 2020. And then our board is made up of all the CEOs of these organizations. They meet quarterly. We asked them when we made our steering committee to please give us individuals who could come together and develop a system and who could make decisions. And they were able to do that. And we initially laid down the foundation of the governance boards, our bylaws. It took us 6 months to get all our lawyers to agree on a consent form that we could sign and use across because we are medical. We do have to have that consent form. Okay, next slide. And so this is just a graph. As you can see, we're slow on volume and numbers. We want to be more impactful and be able to help when someone calls. So these are just a graph of showing how many clients have enrolled. The insurance data has been really, this actually surprised me. We have UT Health System, University of Texas Tyler Health System. They are also studying. It's an independent study of this program. And I do believe most of our individuals are insured. The data collection between entities has been, it's incredibly difficult. We have multiple systems. We have both our hospital systems. Currently, this data you're seeing is only including one of our hospital systems, and it isn't because they don't want to share. It's because of just pulling that data together. We're a low EMS agency, and we've got a spreadsheet that's about 30 miles long that we track all of our nonprofit community partners that help. So the collaborative folks that you saw on the list are not the only ones. We couldn't do it without our food banks and our other nonprofits in our community. We're just now developing, we've released some videos. It's even hard to get hospital employees. So you may go to our community and say, hey, I'm in the GLOW program. And you might get a nurse that goes, so what's that? Okay, because it's still just getting the word out. So we've developed some training videos that we are asking all our partners to send out throughout their HR departments and send out through the city. We have a public facing video. We're just in the process of pushing those out. But with that, pushing out knowledge about your program, you have to have staff to be able to support what you're pushing out. So we are still in the beginning, and we were kind of teetering on, don't tell too many people. I don't know if we can have the capacity to help that many people. So it has been a challenge to grow. I would like to say that as of June 3rd, I will be the community health section chief. It's a new position in the fire department. And so that shows knowledge and expansion in our community's thought process that this is a new part that we need to look at in the whole of our community. And so I'll be heading up that section, and that will be and it will be focusing on this program and collaborating with the other facets of our city, like housing and other resources that we have available. Next slide. This is kind of a heat map. So this goes back to the data question. This is our city data. So this is where we're seeing where we're picking up these individuals and kind of locating them. And this corridor here goes through this middle of our city, and our shelters and our hospital, one of our main hospitals, is along this this corridor here. And then typically this part of our community is more of our poverty area in our community. And so you can see where the heat maps kind of show where we're highlight the areas. We're a little bit different than some of the other where you're targeting an area in your community. We cover the entire city of Longview, and some of our partners cover up into 23 counties and out into Gregg County. But because we're the city is the backbone, we have offered partnerships to other EMS agencies to come alongside, and the hospital systems have those EMS agencies. But if you don't know, an ambulance service gets paid only for transport. So we are covered under TxDOT. And although we're a medical entity and we do medical care, we do not receive any payment for services unless we transport you to the hospital. So this is why it's challenging for a private EMS agency to join in this fight and in this help process, because they're more of a reactive system. And what we want to develop in our city, we can put more and more ambulances in place to take people to the ED for things that doesn't really solve their real issues. Or we can invest in our community as a city and say, how can we do this proactively and identify the individuals that are needing help and then develop ways to shore them up and get them located to the right facilities. So our plan is to identify the needs of an individual and then circle back with them, help them make their doctor's appointments through our FQHCs and our other clinics, and just circle them back to their doctor. Maybe they haven't gone to their doctor because they don't have transportation, lack of funding for prescriptions. So all the things that most of you are seeing in transportation, housing, prescriptions, lack of access to food, we are now a community resource that they can call the GLOW hotline, and we can help either connect them. We don't want to do it for them. We want to shore them up and teach them how to do it. So which is a process. We don't just attach to someone and then go, okay, here it is, do it. We did you get your appointment? We have their appointments on our calendars. We have a care coordinator that follows back up with them and circles up. Our community health paramedicine folks are the ones that make initial contact and do some evaluation on the needs and looking at their medical needs and their non-medical drivers of health. I had this up here to follow my slides, and I'm just talking away. Okay, so in 20, let's see, what did we say here? It's already said that. So we came up in 2020. We started at the end of COVID, and time flies now. It's 2024. Oh my. Okay. So it's 2024, and we still have a long way to go. I think we've made strides. Our data is our main focus as far as harnessing. We want every community partner, nonprofits alike, to highlight the work that they do, because in your communities, nobody can do it alone. These collaboratives is the only way. You can't do it on your own. And I think coming together collaboratively and looking at the different aspects of what we're dealing with, hospital data is tricky. What we find is these individuals go to the hospital for foot pain, chest pain. And the foot pain is caused because I'm homeless. I have a mental health issue. I'm able to get my medicines. And if I could get my medicines, I'm not able to take them adequately. And my foot pain's from CHF that's untreated, right? So you're dealing with mental health, you're dealing with social issues, and you're also dealing with medical issues. And you can't just treat any one of those. Greater Longview Optimal Wellness is our team developed the name and GLOW for short. And that team, that was looking at the concept of all of us, that we're healthy when we're healthy, not just physically, but mentally, spiritually. And so optimal wellness is when you're whole all the way around. And we want to give opportunity to our community. If our individuals in our community are healthy, then our community's healthy. And so, how can we work together? Another thing of that is new is the fire department coming in and doing this, right? If you'll know, we are sometimes our individuals won't let home health care into their home unless we endorse them. Because they trust us, because we're in their house 4 times a day. We're putting them, if you don't know, your fire department and your EMS services often will go change someone and put them back in bed, or they'll call for a lift assist, and they may make them a sandwich before they leave the house. So they're not just putting out fires, they're responding. 80% of what we do is a medical response. And so, that's not just us, that's any of your services. And we're proud to do it. We're here to serve the community, and we're expanding those services by looking at better ways and more effective ways that we can help our citizens by helping them attach to the right services versus using the ED services. I'm probably talking fast. So this is kind of how the system works. Obviously, if you call 911, you would get your normal ambulance, fire, police response, depending on the type of call. But if we identify someone that they're calling and they need more services, this gives them an opportunity to engage and get the consent signed. Once the consent is signed, we can we can either take them to the hospital, or if it is they don't need to go to the hospital, we can start working with them to connect them to a clinic. And we are able through our partnerships to sometimes get accelerated appointments just to mitigate for that day, and get them stabilized. We work with our partners and of course only do that when it's necessary. If someone can hold out for a longer appointment, then we'll schedule them out and we work together. We have an app, well, I'll finish this. So then they would sign the consent form. We'd fill out their CMS form and decide what their plan was or where they thought their plan needed to be. And then we would follow up with our paramedicine team. They go out proactively, not with lights and sirens, and they just, we know where our individuals live. We have a police outreach team that works with our homeless as well. And so we're also developing, which I know many communities have this. This is new for our community. Mental health was in these individuals was high, as you all know. And so we are working now to develop a mental health response in collaboration as part of the GLOW response. GLOW is the overarching response, and underneath that response, we have police, fire, hospital, clinics, and all the other nonprofits that work together. GLOW is the collaborative of these services. We have an app called Pulsera, and we use it currently in EMS for STEMIs and strokes to notify the ED. And then when the charge nurse receives that from the paramedics, that it'll dispatch within their hospital. You know, back in the day, we used to have to call all the doctors and call the people. Now, with just a touch of the button, we have this communication app. And the state of Texas has adopted this app, and they used it during COVID to move patients through hospitals throughout the state where there were vents and where people could go, as that wave came across the state. And so they've allowed us to use this platform. EMS currently uses it, and our region is going to that way. We also use it for mass casualty and for patient reunification for disasters. And they've allowed us to use it in the GLOW program, and we are able to collaborate real time with our partners on issues. And it's basically, think of it as a group text where I consult in whichever partner needs to be. It may not be all partners consulted in, but once you're consulted in, you can see everything that's going on with the individual, and we can just say, hey, we need this appointment, versus making phone calls. And it goes, each agency developed a tree within their organization of how that response gets collected in, and they can dispatch it throughout their agency to crisis teams or whatever is appropriate for the individual, depending on what's happening. So right now, again, we looked at our data currently is showing only the patients. Originally you saw the 119. That is the overall patient numbers. The data that we're looking at for the UT study is someone who's been in the program for 12 months. We're taking and looking at the individual's history 12 months prior to the GLOW consent. And then after the GLOW consent, what does that look like as far as ED and 911 usage? And you could see that that the dollars are going down. We've made really great impacts in individuals' lives, and case study after case study. So we're looking forward to continuing this work. We're really new, and we're still developing other aspects of our program. I think that's my last slide in this. Yeah.
I'd like to invite all three of our fantastic panelists up. So you all, time is yours for questions. We'll start in the room. We'll be floating mic. See a question in the back. If you want to stand, I can just, if you can project, I can project so we can get to your question.
Thank you so much. This is fantastic, and what incredible work you all are doing. You each talked a little bit about your financing and how you're funding this. I was wondering if you could just give a little bit more detail about what it looks like to build that, how it's, who are those key financing sources, and how you're thinking about it, Mom.
Great. And just to restate the question is each of our three panelists addressed financing, and you're asking for just more elaboration on the financing sources.
Well, I was just whispering to CJ that I had maybe some public agency envy. The fact that you all are a public agency that's kind of leading this at the city level I think is different from our experience. I think we're like a bunch of like scrappy nonprofits that have been desperately trying to pull in public health agencies to partner, and they have come to us when I think it suited their needs. In particular, during COVID, they found that they got much higher utilization of they had a much higher success rate of shots in arms, vaccine shots in arms, when they collaborated with kind of trusted neighborhood institutions. But since since that has gone away or it has been de-emphasized, I think we've gone back to this, like trying to get them on the phone, like trying to figure out like, hey, public health agency, like how can you help educate us so that we can get kind of into the CalAIM system. So we have unfortunately been funded by grants. And we have tried to do some collaborative grant raising between organizations, which is always really challenging. It's difficult. It's sensitive. Money is always sensitive, but we do not have a long-term kind of source of funding for this work. And so I am raising money year to year.
So we're believe it or not, kind of similar to that in that the Glow Collaborative is grant funded. The new position, my new position, is going to be grant funded currently. But I will say the luxury, or maybe not luxury, of being with the city is that when it's a need in your community, you just do it. So I've been doing 3 jobs, and I'm going to be glad to do 1 job in June. I'm training my EMS predecessor. And so, we kind of reached the point, everyone wants to see data to decide if we should invest in this. And 119 patients out of 22,000 calls a year is not really that many. But at some point, the city had to choose and say, okay, we think this could be a good thing. And so it's kind of an investment for them to go this route. And so we still in the city do not have enough employees to run the GLOW program. We're still working on expanding that, and that's why we've grown very slowly and why it takes partners to collaborate. But I will say, being a part of the city, there is some infrastructure there, obviously, that is going to be stable, and our city has many grant-funded programs that have sustained over time. So I do believe this is really new, that they've really committed to this project with the development of the new position, and then hopefully currently, I was an EMS chief. I have EMS officers underneath me, which were also serving as those community paramedics that I talked about for GLOW. So the EMS section was really carrying the burden for this project. And so I think they're going to be expanding. So obviously city funding is definitely a positive and is sustainable, but any extras that we're getting, any funding for helping people with prescriptions or things like that, is all from grant funding at this time.
And then I would just, I think, having learned a little bit about your work, also there might be other categorical federal grants, right? Like SAMHSA, and you all think had some funding from a non-health agency before. And then as we've heard, right, it's the guardrails around what would be considered billable for insurance purposes. So some subset of what's being described could potentially be billed, but then we've heard about making sure that you have the infrastructure and administrative support in place in order to facilitate that process.
So for example, we're working on all of us becoming CHWs in case that funding comes in, because even just the fee for an assessment, these individuals, we don't want them to pay out of pocket. And typically what happens now is when you get an ambulance run, they charge your insurance, and then whatever the balance of the bill is goes to the individual. Most of these individuals in this program, they would be, those balances would get written off by the city. So that is what the city contributes, is those bills don't go to the individual. Eventually they get written off. But having a way to just bill for those assessments, going out and doing that assessment with the individual for us to do it would really be a positive thing and help us sustain this kind of work, which would save money, as you saw, in the long run, because an ambulance isn't going out doing that assessment and taking them to the ED for food. So, yeah.
Yes. I see, and we have an initiative that's similar in Chicago, and I see that the hospitalization has decreased. right? And so in a way, you almost have a wrong pocket kind of problem that the hospitals are benefiting. Are any of the hospitals investing in what you're doing in Longview?
They are at the table, and it is a shift. They are investing in time and development, but there's, having initiatives for the hospital to engage in these type of community projects would help them get the investment. It would also, give them incentive to, because if you look at hospital data, and the UT folks that are studying GLOW they're also doing a qualitative study as well, because like I said, if an individual calls for foot pain every day and they go to the ED, what is the ED bill? They bill foot pain. If I go to the ED 4 times a day for foot pain, there might be something else going on, or you haven't solved my foot pain issue. And so why haven't you solved it? And so, giving incentive, those don't count as readmits, right? Because those are just ED visits and they get to bill for that whole every time. And so, sorry, hospital friends. But I mean, that's just how it is. And so our system needs some adjustments. There needs to be incentive on both sides, for us to look at it, because we don't see it. If you just pull data points and you don't dig into those data points, you can have all the data points in the world, but they're really not giving you what's really going on with the individual. So
thank you.
Shall we go? Any questions online?
Yes, we do have one virtual question from Jolie Dixon. They ask, how are you including transportation in your plan? If there are not universal mobility in neighborhoods, then people cannot get to these resources.
It's a great question. Transportation.
I want to talk about briefly. We'll share that we provide vouchers for our Clipper card system for folks to be able to access public transportation. And we're transportation rich in Oakland. We're near BART station, which is our rail station, major bus lines. And so those Clipper cards help when we can get funding for it, for those to continue.
So we have city transit as well, but I will say these individuals that we're identifying, they don't have the capacity sometimes, especially at this critical moment when they're maybe unstable medically, or they may not have the capacity at that moment to take the public transit or the funding. So if you're signed up through the GLOW program, we help you get to your appointments. Obviously, that's not what we want to do for the long term. We want to get you stabilized medically and get you to the resources you need, like food and things like that. And then once we get you established with resources, we want to work with you to transition for a longer term. Maybe like with Medicaid, there's transportation options, but maybe an individual doesn't know how to sign up for those options. We want to come alongside them and look at their insurance and see how we can help them sign up for sustainable transportation opportunities in the future. The unfunded portion of that is I have not had time to dig into all of those individuals to really look at that. They just compiled that, and I was really surprised because our initial numbers, everyone was funded. And I wonder if, when we had the Medicaid enrollment, if a lot of these individuals did not fall off of funding. And so that's another challenge for a project like GLOW, is to help these individuals re-enroll in some sort of insurance. And so that's another thing that we do from the office, is just get that information and walk them through filling out the paperwork with them. So.
And this, just to connect that question back to the earlier question about the sustainability and funding picture, this also just underscores the importance of having the different sectors at the table, right? Because as Ener asked in the beginning, most of the people in the room are health folks. So you may know what the guardrails are, what you can do within the context of your financing mechanisms in the healthcare system, but your transportation colleagues will be best positioned to figure out, how do we best leverage and utilize those resources, and thinking about, whether it's Department of Transportation funding or other sources that may be available in order to pull in and address things comprehensively. So it just reinforces the importance of having the right table and having the various sectors at the table to really work comprehensively to address a whole person's needs. I think we have time for one more question. Anyone in the room?
Thanks so much for the presentation. I saw that you all have a community health center in your network, and I was wondering, I couldn't see on the slide if Glow works with any community health clinics, just when I think about that longer term medical care for some of your ED overusers, if there's any working in your region that you can connect them to for more ongoing primary care services.
Yep. So we have 2 FQHCs that are part of the project, Special Health Resources and Wellness Point. And then both our hospitals also have clinics, so the individual can choose which doctor and which place they want to go to, and we just help them connect to whichever one they want for long-term care. And then follow up to make sure they make their appointments. The other thing about Glow is it's not meant to just be EMS referring out. It's a back and forth referral. So if I'm at a clinic and I identify someone that doesn't come to their appointments and I keep scheduling them and they're no-shows, they can sign that individual up for, call them and ask, or if they need us to go out to the home and say, hey, would you like to be a part of this program? We'll help you make your appointments. Then they can refer as well. So our referrals go both ways from all partners referring in as needed.
It's great. And I think that also just underscores that point, the no wrong door approach, right? So I think that's something that we've heard from CMS consistently, and all of us doing this work, the importance of making sure that wherever you're presenting, whatever needs are presenting first, that we're addressing what's presenting, but then beneath the surface, right? What are the contributing factors? And I think it's been very interesting to hear about how a housing centric innovation has evolved, and taking into account other considerations, and then looking at the data and why we have people showing up in the emergency department for things that do not belong in the emergency department. So then how do we address the underlying contributing factors and make sure that people are getting the full set of health and social needs met?
I wanted to make one more point. We're working with our nursing schools in the area. They do community clinicals for community health. And to your point, I think it's important for us to change our mindset. And nurses that come up, I'm just using nurses as an example. You can say paramedics, you can say whatever. We work in our silo, and I do this. I give them the medicines. I do this. And so we only take care of them instead of looking at the whole person. If you go to I heard at one of the conferences I went to, a pediatrician was like, they come in and I see they need food, but I don't have a mechanism to kick that off. And so for our community, my vision for Glow would be that we would be a referral for those doctors. If they identified, they could have consent forms in their office, get them filled out right there, and then refer to us to help connect the nonprofits. And so just kind of that back and forth. But I think it's changing the mindset and not just looking at the person as a whole, not just looking at, I give the shot today, or I take them to the hospital and I drop them off, but what do they need all the way around, which makes our communities better in the long run.
Kudos to you all for building this umbrella of trust. It's like all under this brand. Folks know that the doctors or the providers that they're working with are connected to the community partners who, these patients know and know that they're going to get the adequate services. So,
well, thank you to Ener, to CJ, and to Amy.
Thank you.